Morning, everyone. Just going to give it another minute until we start. We're just letting people in, etc. So be with you in about 1 minute. Right. Hello, good morning. Welcome everybody to today's webinar. So today we're going to be looking at making life easier with assess, prepare, treat with a focus on wound infection. My name's Sam Wharton. I'm a tissue viability nurse advisor for Coloplast, and today I'm joined by Charlie Pick, who is also a tissue viability nurse advisor for Coloplast. Charlie will be manning the chat, so if you have any questions or comments, please pop them in the chat and Charlie can talk to you. And then at the end of the presentation, hopefully if we've got some time, we can have some time then if anyone wants to open up their mic and come and talk to us. So I shall get on with the presentation. So the objectives of today's session is to introduce you to the Coloplast three-step approach. So this is a step-by-step framework to effectively assess, prepare and treat infected wounds and biofilms. You will learn how this simplified approach will help you to heal your wounds that you have and the wounds that you're seeing, understand the impact of wound infection and biofilms on your patients, and why sometimes those wounds become infected and why those biofilms are present in those wound beds and disrupt that healing process. We'll also look at the latest principles of best practice from the International Wound Infection Institute, and there's a pathway, and we'll leave you with the Coloplast three-step approach wound infection pathway to support your practice. So firstly, we're just going to talk about that burden of wounds, specifically looking at sort of wound infection and biofilm. So we know from recent studies, so Julian Guest did a big study back in 2012, and there was a repeat of that study back in using data from 2017-18, and we know that there are 3.8 million patients with a wound that are managed by the NHS annually. And the cost of managing those wounds was estimated to be 2.7 billion compared with 5.6 billion for those 30% of wounds that did not heal. And wounds that become infected, wounds that have that biofilm sat inside them, they will end up being those non-healing chronic wounds and increase that cost to the NHS. It's estimated that 59% of chronic wounds heal if there was no evidence of infection, compared with 45% if there was a definite or suspected infection. So we know that wound infection is really causing that complication in wounds progressing and healing for our patients. The prevalence of biofilm, so it's evidence that it's up to 80% or higher. So chronic long-standing wounds that are non-healing, there's an 80% to 100% chance that there's that biofilm sat in there. And as we go through this presentation, we'll be looking more into biofilms and how they affect that wound healing process and why it's really important that we're using wound preparation to disrupt and break down that polysaccharide that protects those biofilms to ensure that we're getting those wounds to heal. And we know that wound infection is a challenge for clinicians. In a study that was carried out, 46% of healthcare professionals believe that infection in a wound is challenging. But I actually, from my years of teaching, believe that that's a lot higher. I think that wound infection can really cause lots of challenges And hopefully following this presentation, you'll have a bit more confidence and understanding on how you can help patients' wounds to progress and remove that infection. So the clinical relevance of wound infection. Infection is a common wound complication, but it is often difficult to identify. We know that our bodies have our natural microorganisms sitting in them, and once that skin has a break in it, those microorganisms infiltrate into that wound. When we've got a normal immune system, our own defences can manage those microorganisms and they don't cause any issues. But it's when those microorganisms move deeper into the wound and start proliferating, so they start multiplying, that's when you have an issue and where that wound infection occurs. And that leads to that local or systemic immune response. The host immune system and species of microorganisms will also influence the development of that wound infection, and also the cause of the wound will also contribute to if a wound is going to get infected. So in the event of an infection, that wound healing is delayed, that patient's quality of life can be adversely impacted, and we're going to look at that in more detail as we go through today's presentation. Obviously, treatment costs rise. So when we think about treatment costs, it's not just the products that we're using, but when there's wound infection present, it's the swabs, it's the antibiotics. If a patient then ends up developing a cellulitis, it's that hospital admission. If they get sepsis, so you know that there's that constant rise in costs. Biopsies, any other diagnostics that may be needed, again, just all add to that cost, which also leads to that wound needing more resources clinically. So usually will be a lot more resource dependent on clinicians, so increased visits, increased clinic visits, dressings will need to be changed more frequently. So it's really important that we do that holistic approach and do a proper assessment and identify those risks that patient has that may cause them a greater risk to get an infection. If we do that right at the beginning, many problems can be avoided and clinical outcomes can be improved. So as always, prevention is always a lot easier than cure. So again, as we go through this presentation, hopefully we can identify and help give you some support in identifying those high-risk patients. So I'd just like to introduce you to the Coloplast three-step approach. And this is our simplifying wound healing approach. And it's really simple. As you can see in front of you, there's 3 steps. So that first step is doing that assessment. And it's really paramount that when we're looking at our patients, we look at the whole of the patient, not the hole in the patient. So within this assessment, you need to be identifying and reviewing psychosocial factors that may be influencing that patient's ability to heal. Look at that patient's comorbidities, their age, their mobility, what medications they're on, have they got diabetes? We need to identify all of this really importantly at that first assessment. Then we can make sure we're going to optimize that patient to ensure that they're getting that optimal chance to heal. We then look at the actual wound. So we're looking at that wound bed, wound edge, and peri-wound skin. So again, throughout my career as a tissue viability nurse, I think many clinicians become very focused on just that wound bed, when actually, if your wound edge isn't optimized, then those epithelial cells won't be able to migrate across and close that wound. If your peri-wound skin isn't healthy, if it's dry, if it's too wet, again, you're going to have other contributing factors that are going to delay that healing. So that's why we look at all 3 sections, just as important as each other. So once we've done that really robust, thorough, holistic assessment, we then move on to our step 2, which is prepare. So wound preparation is key, it really is. And I think we're learning more and more about the importance of preparing our wounds adequately to remove those biofilms, disrupt those biofilms, and dislodge any slough tissue, non-viable tissue that's present, so that we're really optimizing that wound's opportunity to heal. And it's something we need to do regularly, frequently, and it is a really equal part of this assessment to be done. So we've got our assessment, our preparation. So once you've done that really good wound preparation, sometimes you might have to go back to your assessment because actually you've removed large amounts of devitalized sloughy tissue, and you can visualize that wound bed a bit more, and you may need to be changing what your initial thoughts were. So assess, prepare, then we move on to treat. So by doing a thorough assessment, preparing that wound, we should know what our management goals are, and that will lead us to choose the most appropriate dressing to manage the wound, looking at the depth of the wound and the stage of healing it's at. So we're going to go through each of these steps relating it to wound infection. So our first step is assess. So what is the aims of wound assessment? Firstly, it's to identify that cause of skin breakdown. And it seems really silly saying it now, but the amount of patients that I have seen throughout my career that have not had a diagnosis or that cause of that wound identified is phenomenal. And I think as clinicians, we're becoming more and more aware of the need to identify the cause of breakdown, but we can still do better. So for example, I had a wound clinic and people would come in with a skin tear on their leg that had been there for 6 months. Well, that's not just a skin tear, that's now a leg ulcer. And we need to identify what etiology that leg ulcer is. So it's really important that we do get that cause of skin breakdown right at the beginning. Sometimes we can get it wrong, but then that's where you utilize your specialists or refer on if things aren't progressing as you would expect. If it's a pressure ulcer, we need to make sure we're removing that pressure. Otherwise, that wound is just going to continue to break down. Also, we need to identify associated risk factors. We need to correct or treat that underlying cause. So again, if we're thinking about our leg ulcers, we need to be getting that patient into compression therapy if that's what's needed. If they've been identified as having a venous leg ulcer, they need that strong compression, therefore treating that underlying cause. Identify appropriate management options. So, you know, so not everybody can have the gold standard, but maybe because of other comorbidities, but we need to look at what those options are. Control those wound-related symptoms. So if there's large, copious amounts of exudate, we need to make sure that we're managing that so that then that peri-wound skin's not going to break down. And also it allows for that conversation and communication with your patient to make sure that their expectations are realistic, and provide that psychosocial support and promote patient independence. So how often should a wound assessment be carried out? Well, anytime you're taking down a dressing, you'll be looking at that dressing, looking at the exudate, how much exudate is present, and you'll be doing a review of that wound. But an actual full holistic assessment where you are really looking in detail at everything around that patient should be done every 2 weeks in an acute setting and every 4 weeks within a primary care and community setting. And this is a minimum, because if there's been a change or something's happened within that patient or the wound, then you would be doing it more frequently. It's really important that we listen to our patients. The patients are the expert in their wounds. We need to be able to sit and listen and hear what's happened to them within their journey, what dressings have been tried in the past, building that rapport with the patient, looking at their medication. Often patients would come in with a script of medication. Well, actually, they weren't taking half of what that was on there. So actually having that conversation to find out what medication they are taking and what they're remitting. You look at their age, their body weight, their mobility, and their general demeanour. Are they anxious? Are they tired? Are they confused? And when you're thinking about wound infection, you know, are they looking sweaty? Do they look unwell? Do we need to do some observations? Are they getting those systematic infection going on? Are they becoming quite unwell? And always looking at that previous dressing. So for me, I love a dressing, and I used to go and do joint visits with district nurses or nursing home patients, and the dressings have been taken down and they cleanse the leg which was really kind, but then I'd have to go and dig around in the bin to get that dressing out, because for me, I get so much information from a dressing. You can look at the exudate, you can see if it's contained within the dressing. So much information is contained within them. Then you do your top to toe skin assessment. And the things you're sort of looking for is that dry skin, wet skin, macerated. Are the patients incontinent? Do they have edema? If there's anything on the lower legs, a pulse is present or absent. Talking to your patient, what's their pain like? Is there any inflammation? Is there non-blanchable erythema? Are those signs of localized infection present, whether they're subtle or classic signs? Or is there actually a spreading erythema beyond that 2 centimeters, and it's now turning into more of a systemic infection? So there's so much that we need to be gathering when we're doing that assessment of our patients. And something that's sometimes very undervalued is that odor. So it can provide useful information about that skin condition. It should be done sensitively. So I've had patients where you can sort of smell their wound before you see them, and some like Pseudomonas has a very distinct smell, and you know straight away what's contained when in that wound when you can smell that Pseudomonas smell. We do need to be sensitive when we address it, but can you think of the impact that's going to have on your patient, that odor? I had a gentleman that used to get the bus to come to clinic, and he had some unkind comments, and people moved away from him, so he ended up stop going on the bus and became very socially isolated. He would only get a taxi to clinic, which obviously had a financial impact on him. I've had another patient where she refused her family to come and see her. She had an ischemic leg, and there was no further treatment for her, but the odor was so bad, she didn't want to distress her family. So actually, you know, coming into those end of life, she didn't see her family. So, you know, odor can have a real impact on patients. It can also give you some ideas on what's happening with their own hygiene. So patients in leg dressings, sometimes you'll see urine that's on them, and you just need to sensitively have that conversation if they're struggling to get to the toilet. Also, that wound exudate that has an odor, and if there's wound infection, again talking about Pseudomonas, you know, it's got that very distinct smell, and wounds will become more odorous with infection. If there's that necrotic, sloughy tissue sitting in a wound, again, that will be making that odor worse. And malignancy, again, has a very distinct smell, and can be very distressing to patients. So we need to address this when we're looking at assessment of patients. So we've discussed slightly about the triangle of wound assessment. So it's a holistic wound assessment looking at the wound bed, wound edge, and peri-wound skin of the patient. And it's to support optimal clinical decision making within all of those areas. So first of all, we're going to wound bed. So we need to be looking at what types of tissue are present. Is there necrotic tissue? Is it hard necrosis? Is it soft necrosis? Is there sloughy tissue, granulating, epithelializing, which we'd obviously like to see within our wounds? The exudate. So I've already talked a bit about this exudate. So is the volume dry, low, medium, high? What's the consistency? Is it thin and watery? Is it thick and purulent? What color is it? Is it pink? Is it clear? Is it straw colored? All of these need to be documented and reviewed when you're looking at that wound bed. And then you would be looking at those signs of infection. So you've got your local signs of infection. So you have your subtle signs like that friable granulation tissue. When you go to cleanse it, it bleeds really easily, often quite darker in color than that nice pink granulation that doesn't bleed so easily. And then you have your more classic signs, so that erythema, edema, increase in exudate. And then you've got your spreading systemic signs of infection, so that erythema is spreading beyond that 2 centimeters of that wound bed. Often the patients will say they don't feel very well, they've just got a general malaise. If they've had bloods taken, often they'll have raised white blood cell count. And yeah, they're getting quite unwell at this point. And then you've got your wound edge. So when we're looking at our wound edge, we're looking to see if there's any maceration. So you can see a really good photo there on the top left of that maceration, that white ring around that wound. And those cells are being filled with fluid, and they're very delicate, and they will just break down, and therefore increasing the size of that wound. Or is the wound edge dehydrated? Do we need to give some moisture there? Because if that wound's dehydrated, those epithelial cells won't be able to migrate across. They need moisture to be able to slide over each other to close that gap and heal that wound. Undermining, we need to make sure we're recording it so that everybody knows whereabouts that undermining is and how far it's undermining. So we often use sort of the clock. So the 12 o'clock is the head, 6 o'clock is the feet, and you would therefore use that as your guide so that everybody knows where that undermining is. And then you've got rolled edges. So again, really hard to manage the rolled edges. Once they're there, you can do sort of some refashioning and trying to really agitate those wound edges. Sometimes they'll need surgical intervention, and also just to be aware that if they're rolled edges and they're not resolving with your normal treatment, that it's often worth referring to dermatology for a biopsy, because it can be a sign of malignancy. And then we move on to that peri-wound skin assessment. So again, we're looking at that maceration. So that top left photo, you can see there is the maceration on that wound edge, but actually as you look further down where that skin's wrinkling, you've got loads of maceration. And what's going to happen over time, if that exudate isn't managed, is that whole wound's just going to open up, and there's going to be a real issue with trying to get that healed. Excoriation, so you can see just that really dry red area can be caused by dressings being taken on and off. It needs moisture. It's just crying out for some moisture. And again, with our dry skin, I often think about when I've removed heads in the past, head stockings that have been on for too long, and you sort of get that snow globe effect. You know, we need to be making sure we're optimizing patient's skin and moisturizing it and keeping it as healthy as possible. The bottom row, so we've got that hyperkeratosis. Whenever I see this photo, I just want to pick and get at it with a pad to try and remove that, because you know how hard that's going to feel for that patient. Very itchy. It can sometimes feel very hard, and it needs to be removed. Callus, that's often sort of dealt with by podiatry, often seen in diabetic foot ulcers, and that needs removing again. And then you've got that eczema, that red pustule looking breakdown in the skin. Again, we need to be identifying what that cause of that eczema is. If it's venous eczema, they need compression. We need to be making that diagnosis and managing that peri-wound skin. So who is at risk of a wound infection? So you've got individual risks and environmental. So I'm not going to go through all of these. So with your individual risk, you know, your poorly controlled diabetics, we need to be trying to optimize and making sure we're getting on top of their blood sugars. What medications they're taking can also put them at more risk. If they're immunosuppressant or on cytotoxic medications, they're going to be a lot more at risk of wound infection. Alcohol, smoking and drug abuse will also put patients at more risk. Nutrition, either over nutritioned or under nutrition, they'll be more prone to risk of wound infection. And then looking at those environmental risks, so hospitalization, if you're in hospital, the longer you're in there, the more at risk you will be of picking up infections. Unhygienic environments. I've been a community nurse and been in some very unhygienic environments. I've been to houses where there's hoarders, often a lot more bacteria sort of within that environment. Poor hygiene and aseptic techniques. So that's not only the patient, but also clinicians. If we're not using and optimizing our clean environment, we can actually introduce microbes into our wounds. I've also had patients where I've taken dressings down and they've wanted to point things out and stuck their fingers in, and they've got long nails, and it's having that conversation and trying to make sure we keep it as clean as possible. Also, that repeated trauma, such as an inappropriate dressing being removed constantly and causing that trauma to that skin, it can then start breaking it down and make it more vulnerable to infection. Here are just some wound characteristics which predispose someone to infection. So you've got that for that acute wounds, chronic wounds, and then in the middle that will predispose that wound to more chance of infection on both of them. So again, I'm not going to go through all of these, but with those acute wounds, so contaminated or dirty wounds, I've had many patients that have caught their lower legs on commodes, for example. That would be a dirty wound because that it's been caused by a dirty commode, and you need to be more vigilant of infections. Inappropriate hair removal, pre-existing infection, all of those will make those acute wounds more prone to infection. A chronic wound, so what's going to make that more predisposed to infection? Well, how long has it been there? The longer it's there, the more chance there's going to be infection, and definitely there will be biofilm there. The size and the depth of the wound and where it is anatomically. And then what makes both of those, both acute and chronic wounds, more susceptible is that necrotic tissue or foreign body being present. What's that tissue perfusion like? Is there a hematoma? And again, that increased exudate or moisture. Now we're just going to quickly take a look at the wound infection continuum. So this is just the WIIW wound infection continuum, which goes from contaminated down to your systemic signs of infection, and obviously biofilm sits across all of those. So when we're talking about our contamination and colonization, that's where our microbes infiltrate into that wound bed, but then managed by the person's own immunity, so they don't cause any issue to that person. There's no signs of infection, and the body's just keeping on top of it, and the wound will progress to healing. If it then goes into that local infection, that's where those microorganisms are proliferating and moving deeper into the wound bed, and they'll cause that reaction to the patient. So you'll see those subtle signs of infection or more classic signs of infection. Those microorganisms are multiplying, and they're causing a natural response to the patient. So just a quick overview of those subtle symptoms. So that hypergranulation, bleeding, epithelial bridging, that wound will start to break down. There'll be a delayed healing and an increase in malodor and pain. And then those more classic symptoms, that erythema, heat, swelling, purulent discharge, delayed healing, and again, pain and malodor. Then we move further along that continuum, we're moving into that spreading infection. So this is where those microorganisms are proliferating even more, and they're invading that surrounding tissue. The patient may well still show those subtle signs as well as the classic symptoms, but they'll also start demonstrating some of those early systematic infection indicators. And then our systematic infection. So this is where that patient really needs urgent medical intervention, because they are really at risk now. They could end up with sepsis, organ dysfunction, systemic inflammatory response. That infection's now spreading throughout the body via the vascular and lymphatic system, and that patient's really at risk. And then alongside our local infection over to our systemic infection, we have biofilm. So like I was saying, the biofilm is a structured community of microorganisms, and they create that chronic infection. They're not visible to the eye, but they show signs the same as infection if they're indicated within that wound. So those local signs of infection may also be that biofilm presence. Some common microorganisms in the wound. So we've already talked about Pseudomonas with that really classic odor and that green exudate. So it's a gram-negative microorganism, and it's believed to reside deeper in the wound tissues. And again, it is a keen biofilm former. So once it's there, it's really, really hard to remove from that wound bed. It prefers larger sizes, and it's seen in over 50% of chronic leg ulcers. So if you're seeing patients with leg ulcers, a large majority of those will contain that Pseudomonas. And then we've got our Staphylococcus. The well-known type is MRSA, which is still continuing to cause mortality rates of 28 to 38%. This is a gram-positive bacteria. Again, it's a very keen biofilm former, and its infections can range from sort of very minor self-limited skin infections to really invasive life-threatening infections. So when do we swab? You would follow your own local protocols, but if there's those acute wounds with classic signs of infection, then you would swab. Chronic wounds with signs of spreading or systemic infection, again, really important that you're taking that swab at that point to make sure that you're treating that infection with the most appropriate antimicrobial antibiotic. Infected wounds that have failed to respond to antimicrobial treatment or are worsening, again, you could swab then. But again, like I say, follow your local policies and procedures. So that was a very quick whistle-stop tour of the assess part, but as you can see, it's very in-depth, and to do a really good holistic assessment, it takes time. You need to gather a lot of information to make sure that you're going to get that patient onto a healing trajectory. So we've done our assessment. Now we're moving on to our step 2, which is prepare. So like I said before, this is really a fundamental part of our wound treatment, and it's making sure we're optimizing that wound healing environment. So prepare. So slough, non-viable tissue and biofilms can delay that wound healing process. They can increase that risk of infections. Bugs, microorganisms, they love to hide in it. It gives them a nice food resource. There's little nooks and crannies within that sort of slough and non-viable tissue that they can reside in. It also inhibits development of healthy tissue. If you look at that photo to the right, you know, you're not going to get good healing with all that necrotics, that sloughy tissue sitting within that wound bed. And it also limits wound assessment. So we can't really clearly visually see what's lying underneath that until we remove it. And like I said before, 80% of non-healing wounds contain biofilm. This is a really interesting study. It's a retrospective study where they looked at over 317,000 records and looked at how often wounds were debrided and the outcomes from that. So although the study looked at over 317,000 records, this is just what shows you in terms of the diabetic foot ulcers. And again, it's just a really evidence-strong piece that shows that if you debride, cleanse and debride more regularly, you get more positive results. So that graph that's on the page, it's just showing when a wound was debrided once a week, the median time for that wound to heal was 21 days. And if that wound was debrided once every 2 weeks, that median time for it to heal increased to 76 days. So again, you know, it's just providing that evidence that we know that if you cleanse and debride regularly, frequently, you are going to reduce those days that wound's going to be there for that patient. There are many different ways you can cleanse and debride your wounds. So we've got washing and cleansing, which don't require any extended competencies and training. And then we move further down into autolytic debridement. So that's choosing a dressing that's going to provide that moist wound healing, where the body will remove and break down that slough and necrotic tissue from the wound bed. Then there's mechanical debridement. So that's that physical removal of devitalized tissue using friction. So within Coloplast, we have the All Prep pad, which I'll be talking about on the next slide. but that's a really good way of removing that slough, non-viable tissue. And it doesn't require any extended competencies and training, but you will need to have some knowledge and skills around just wound care in general. Then we've got biological debridements, that's maggots. Maggots work really, really well if they've got the right environment. It sometimes can be a bit complex to get the maggots to you for the right time. They need to be made sure that they're kept nice and moist, otherwise they eat each other. And obviously, dependent on where that wound is, if there's too much pressure, they can get squashed. But they do work really well at breaking down that sloughy tissue. And then there's enzymatic debridement, so that's an ointment, gel or dressing that will soften, but you just need to be careful because it is non-selective, and if it's put on healthy tissue, it can therefore break that down. And then the last type is that sort of sharp or surgical debridement, where that needs extended competencies and needs sign off and expertise to be able to do that, and that's done using scalpel, forceps, curettes and scissors. So like I say, this is the international best practice for the management of biofilms and infection. And it's really that three-step approach again. So that first part of this best practice is that wound preparation. So it's to cleanse and debride to reduce the number of microorganisms by disturbing and removing some of that biofilm that's sitting in there. And if you look on the right-hand side, you can see that's the All Prep pad that we have within Coloplast portfolio. And again, it's a really good way of providing mechanical debridement. So that darker grey side of the pad, that disrupts and dislodges the slough and the non-viable tissue, and the lighter side absorbs and removes that debris using its unique slits. And that's can support that step within that international best practice. So how often would wound preparation be required? It's down to your own clinical judgment, but like we've just shown with that evidence, the more regularly it's done, the quicker that wound will heal. And especially if there's wound infection present within that wound bed, we need to be removing those microorganisms, disrupting that biofilm, so that whatever active agent we're putting on top, it's going to be able to be effective. There are times that we should be cautious with wound preparation. So if a patient has a wound on a lower limb and is known to be diabetic, then please discuss that with specialists. I mean, if they've got diabetes, they're more than likely going to be under podiatry, so be guided by them. And it's just to have some caution. If a patient has known arterial flow concerns or poor local tissue perfusion, again, be reaching out to your specialist just to get some additional support. And also if they're on cytotoxic medications or if they're immunosuppressed, because what you don't want to do is start opening up and introducing infection into a wound if they haven't got that immunity to be able to fight off any infection. Now we're moving on to our step 3. So just going to reiterate, we've done our step 1, which is that really robust holistic assessment. We've had a quick whistle-stop tour of that prepare, so removing those barriers to healing to create that optimum wound healing environment. And now we're moving on to treat. So we're going to look at what the treatment options are for patients to ensure that those wounds can progress to healing. So wound assessment and preparation leads to identifying what our objectives are, and we should aim to support an optimum healing environment for that wound. So what we need to be asking ourselves is, what is our treatment objectives? So some examples of objectives may be, we want to manage that exudate. We want to make sure that we're not creating that exudate pooling, which can sometimes happen if the dressing is sitting above and you've got any depth to that wound, you can end up getting this exudate pooling. If you've got a proliferation of microbes in there, you're going to have more, you've created even more of an appropriate environment for them, and they will continue to proliferate. So we need to make sure that your dressing is going to manage that exudate and ensure that exudate pooling doesn't happen. You want to make sure that your dressings are going to protect that peri-wound skin. So when we think back to when we looked at our assessment, you know, we're looking at that wound bed, that wound edge, and that peri-wound skin. It's really important that we're protecting and managing all three parts. So you want your dressing to be able to take that exudate away and protect that peri-wound skin, because you don't want to have maceration or excoriation to that peri-wound skin. You also need to think about what depth that wound is and whether there's any undermining, and how you're going to manage that, and what dressings are available that will help you manage that. And finally, you know, you'll be looking at those signs of infection and biofilm. Is that wound really static? Is it not progressing as you're expecting? Are those subtle signs of local infection there, all those more classic signs? What am I going to use to ensure that we're going to be addressing those and managing those to get that wound to heal? And right at the bottom, again, it's just remembering to identify and treat any of those underlying causes. And that really is just that integral part to wound healing. We need to find out why that skin's broken down. And if there's any underlying causes, we need to be treating those. So going back to that international best practice for the management of biofilms and infection. So we've done that wound preparation. So we discussed and talked about that oil prep pad, how that can support and help you cleanse and debride and optimize that wound environment for that wound to heal. The second part of the international best practice is to apply a barrier dressing that prevents that maceration by managing that exudate and preventing that recontamination. You don't want is that dressing to absorb the exudate away, but actually it can then give it back into that wound, because you're just going to be continuing that infection. And finally, you want dressing that's going to be able to suppress that biofilm formation and reduce those existing biofilms and microorganisms. So you need an active agent within that dressing. So when would you implement an antimicrobial? So when it's contaminated and colonized, you don't need topical antimicrobials at that time, because there's no bioburden. The wounds are continuing to heal. The person's own immunity is managing the microorganisms. They're not proliferating. They're not causing any response. So you just need to monitor the wound at that point, and there's no antimicrobials indicated. When we move along to our local infection, this is where we need to be utilizing our topical antimicrobial dressings, and we need to be getting on top of that infection as soon as possible. So obviously follow your local policies and formularies around what antimicrobial dressings you would use, but you would need to be using an antimicrobial at this point. And then finally, when you're at that signs of spreading and systemic infection, this is where you'll need to be getting those systemic antibiotics on board, but you still need to be treating with that topical antimicrobial dressing as well. So you're sort of double whammy attacking that infection to make sure that we're keeping on top of it and trying to reduce those microorganisms that are proliferating. So this is where you do need to use those systemic antibiotics and a topical antimicrobial. And within all of these sections, you would still be doing that wound preparation, because like I say, prevention is much better than cure. So some of the different types of topical antimicrobials which are available. So we've got liquids, pastes, creams, ointments, sprays, and impregnated dressings. As clinicians, dressings that have the active agent impregnated into them are really easily found now within our formularies, and they ensure that dressings don't need to be changed as frequently, and they all sort of denote that active agent differently, so be aware of how they work. Some are used every day for a short period of time. Some require reapplication several times a day, and some are left in contact with the wound for several days. And the different types of topical antimicrobials used in wound management include honey, PHMB, iodine, and silver. So silver has been used for thousands of years in wound care to prevent or treat that infection. And there's actually an international consensus about that appropriate use of silver dressings in wounds. It's been available in the following forms. So you've got solid elemental form. You've got it as a solution of silver salts used to clean wounds. You can have it as a cream or ointment containing silver antibiotic compounds. But like I say, with the new advanced wound dressings, you get the wound dressings that contain that silver. So that means that it's easier to apply and it provides that sustained release of silver, therefore not needing as much frequent dressing. Although if there's signs of infection, you may still want to be quite vigilant to make sure that the silver dressing is actually working and reducing those local signs of infection. So silver has a broad spectrum antimicrobial effect against bacteria, and it's effective against both gram-negative and gram-positive. And it's also been shown to prevent that biofilm formation. So like I say, with biofilms, you've got that microorganism and it produces this polysaccharide protection around it. And actually, if you're able to disrupt some of that polysaccharide matrix and then put that active agent on top, it will help break down that microorganisms and hopefully stop that reformation of that biofilm. So silver targets multiple sites in bacteria. So it has 3 modes of action. So the first mode of action is it binds to that bacterial cell wall and it blocks any transportation of substances in and out of the cell. So it just blocks any transport of any substance in and out. Then its second mode of action is it transported into the bacterial cell where they block the respiratory system, therefore destroying the energy production for that microorganisms and bacteria. And then finally, in the bacterial cell, silver ions interact with the DNA and therefore inhibit that bacterial cell's division. So it's stopping it replicate. So like I say, it's got these 3 modes of action, which is why silver is quite a good option when you have those local infections. We also need to make sure that we're using our antimicrobials appropriately. So I'm sure most of you have heard about the 2-week challenge, and it's about using your antimicrobial for 2 weeks to determine whether it's actually been effective. It's not that after those 2 weeks you stop using it. It's just that you have that 2-week period and then you reassess to see if it's actually been appropriate in managing what you needed it to. So there's 3 different options. So if you've used it for 2 weeks, improvement and continuing signs of infection, you can therefore continue to use that antimicrobial because it is doing what you want it to do. There's some improvement seen in that wound. If after 2 weeks there's improvement and no signs of infection, so those local, subtle, classic signs of infections have gone, you can then stop using your antimicrobial because it's done what you needed it to do. And your final option is after 2 weeks, there's been no improvement, then you need to be thinking of other antimicrobials that may be able to support. So then changing what dressing you're using. So at Coloplast, we really want to make life easier for yourselves and for your patients. So we've gone through the Coloplast 3-step approach and looking at how we can simplify wound healing with a focus on wound infection. So we've looked at that wound assessment, we've looked at how we can prepare wounds, and finally we've looked at how to treat wounds and what options are available. And now I'm just going to show you a case study which really illustrates how this assess, prepare, treat can support you in clinical practice. So here we've got a case study about Mr. D. So this was a 55-year-old male who had his big toes, left hallux amputated due to type 2 diabetes and arterial insufficiency. Initially, multiple dressings and a daily dressing change regime was in place to manage the exudate levels because they were so high. and they were actually talking about further amputation of the foot because they didn't feel that it was salvable. So at this point, Assess, Prepare, Treat was introduced. So that assessment, the management goals were looked at and how they can create that optimal healing environment. So they needed to remove all that non-viable tissue. They needed to manage that exudate because the dressings were needing to be changed daily. They needed to manage that bacterial burden that was sat within that wound, but also ensure they were protecting any granulation and epithelial tissue and protecting the skin. So that was the really thorough assessment which was carried out. And in terms of preparation, on all prep pad, debridement pad was used. And as part of the treat, it was Biatain Silicone AG. And as you look at those photos, you can see after week 9, what an amazing improvement from day 1. That area where the toe's been amputated is healed. That wound bed's looking nice and pink and healthy. And then when you go to week 14, you know, that what an amazing achievement on someone that's got diabetes and arterial insufficiency, that wound's progressed to that point within 14 weeks. So the results were the wound had decreased in size from 18 by 7 centimetres to 4 by 1 centimetres in just 14 weeks with a very complex patient. The top of the wound where the toe was now healed. The exudate levels to the remaining open areas was low, and there were no signs of localised infection. And what's really, really good to see is the patient's pain score was only 2 out of 10. So that's really an impact that supported him in his quality of life. And the wound no longer required that antimicrobial to manage that bacterial load. And so it was just being treated with Biatain Silicone. So again, it's just showing you the benefits of putting Assess, Prepare, Treat into your wound healing treatment. And finally, we've just got a pathway that you can adopt if you haven't got a pathway already in place. So this is a simplifying wound healing, wound infection pathway. So we've got our patient right at the top of there. So again, addressing all aspects of that patient, looking at the psychosocial factors, the patient factors, their comorbidities, the medication, their age, and then looking at that wound bed, wound edge, and peri-wound skin. From there, we're going to look at, is that wound infected? If there's no signs of infection, we move across to the left-hand side. Is the wound progressing as expected? If it is, great. Is there granulation tissue to the wound bed? Then continue with preparation and your treatment plan. If there's slough and devitalized tissue to that wound bed, make sure that we're preparing that wound for healing. And we need to be making sure that we're really preparing that wound well, because what we don't want to do is, if we're leaving that slough, devitalized tissue in the wound bed, those microorganisms will start to proliferate within that material, because it's just going to be the ideal environment for them. You would also look at your product selection guide and choose an appropriate dressing, but look at what the etiology of the wound is and use that pathway as to what dressing you would use. If the wound is not progressing as you were expecting, there's no signs of infection, but it's just not progressing as you would expect, so it may be a bit of a static wound. That leads you on to, is there a suspected biofilm? Like we say, over 80% of long-standing non-healing wounds will contain a biofilm. And at this point, we need to be thinking, do we need to introduce an active agent as per the international best practice guidelines? So again, we need to be preparing that wound, and then we maybe need to start introducing an active agent to break down those microorganisms. So by doing that wound preparation with that all prep pad, we're disrupting that biofilm, that polysaccharide matrix, and then that active agent can actually be effective within the wound. Then we're going back up to the top. So is that wound infected? Yes. So is there signs of local infection? So thinking back to those subtle signs, those classic signs of infection, then again, we need to be preparing that wound, optimizing that wound healing environment, removing any devitalized sloughy tissue, disrupting that biofilm that will be protecting those microorganisms, and then using that active agents, using that 2 weeks challenge with the antimicrobial treatment. If there's spreading or systemic signs of infection, could it be sepsis? At this point, we need urgent medical review, antibiotics. So you need to be referring on immediately if there's any signs of spreading or systemic infection, to make sure that they're able to get those antibiotics. And then alongside that, you can still be using that wound preparation and an antimicrobial at the same time to attack it from both sides. Then we have our wound infection product selection guide. So this again really simply tells you what you can use to help you with those wounds that are showing signs of infection. So you assess the wound using the wound infection pathway. You would prepare the wound for healing using the All-Prep pad, or follow local guidelines. So like we say, that All-Prep pad, the darker grey, for disrupting, using that friction to remove any slough or devitalized tissue, breaking down that polysaccharide matrix surrounding the biofilm. And then you've got that lighter grey side with unique slits within it that are able to capture and remove the debris out of the wound bed. Then you would go on to your treat. So if it's a superficial wound with local signs of infection, you could treat it using a Biatain Silicone AG or Biatain AG non-adhesive. If it's got a greater depth of more than 2 centimeters, then you would be needing to pack that wound and use a filler. So a Biatain Alginate AG will be able to support you with that. Also, if there's any undermining or tunneling, again, you would need that Biatain Alginate AG to ensure that you're getting that active agent to where it's needed. But you wouldn't need to put a Biatain Silicone AG over the top of that filling material, that alginate, because it won't be in contact with the actual wound bed. So it's really important that when we're looking at our Biatain Silicone range, with Biatain Silicone, you've got 3D fit technology. So that dressing will conform down to 2 centimeters, ensuring that exudate pooling won't be an issue. It absorbs vertically. So again, by absorbing vertically, it'll be protecting that peri-wound skin, and it locks away that exudate, so you don't have to worry about that exudate going back into the wound and causing further infection. So I'm just going to ask Charlie if there's been any questions or anything, as we've got a few minutes left.
Hi Sam, brilliant, thank you very much. There's been a couple of questions that I've answered in the chat. A few people saying around overgranulation or hypergranulation tissue, and how to manage hypergranulation. And I have advised that it is a symptom of wound infection or biofilm. So we need to make sure we're preparing that wound and then using an antimicrobial, dependent on what's on the formulary for that patient. Also, we had Michelle, who suggested that sometimes clinical staff get a little bit distracted by the mindset of always needing to put a primary dressing into a wound, like a contact layer, and then sometimes if we're then using a silver over the top of that, it's not able to penetrate where it needs. So I have just reiterated around the use of like Biatain Silicone or Biatain Silicone AG, and how they already have that inbuilt contact layer, so they don't need to put a contact layer underneath it.
Yeah, absolutely, because what you're doing is, if you're putting a contact layer underneath, then you're just completely stopping that active agent being able to be in contact with those microorganisms and do what it needs to do. So it is really important that we know how our dressings work and use them appropriately. I've got 1 more minute, so I'm just going to let you know about some future webinars we've got coming up. So in February, we're doing Assess, Prepare, Treat, looking at the etiology of skin tears. So if you want to sign up for, we're doing a sort of a daytime and an evening session. And then in March, we're doing Assess, Prepare, Treat, Making Life Easier, looking at pressure ulcers. Again, we've got a daytime slot and an evening slot. We've also, if you like podcasts, we've got a new podcast that's just come out on different platforms like Spotify, and it's called Wound Care Conversations. Again, please sign up and like if and subscribe if it's something that you like doing, listening to podcasts. So that's it from me. Thank you so much for taking time out of your busy working day to come and listen. I hope it's been useful, and hopefully see you at another webinar soon. Thank you.
Bye.